Welcome, everyone, to our EPI-WIN webinar on the outbreak in Sudan Ebola virus. We'll just wait a few minutes for everyone to join, just 1 or 2 minutes more. While we're waiting, please introduce yourself and where you come from on the chat. We're very happy to have you here. So I think I'll begin now. So good afternoon and good morning to those of you joining from the West, and good evening to those of you joining from the East. Welcome once again to our WHO EPI-WIN webinar. Today we are talking about a very important topic, the Sudan Ebola virus and the current outbreak due to this virus. And we have two experts joining us from the WHO Regional Office for Africa. We have Dr. Otim Patrick Kosi Ramadan, who's an epidemiologist with wide experience, who's working on the field right now. And then we have Miriam Nanyunja, who's a regional advisor for emergency risk management. Both of them have been working on this outbreak, and they will give you an overview of this virus first, and then the current outbreak. Please, if you have any questions, put it in the Q&A. We'll try and answer as much as possible. And at the end of the session, we will have a Q&A. So your questions will be answered directly by the experts. This is being recorded, and we also have a live YouTube link. So you can watch it on YouTube as well. And you can watch the recording later. It will be put on our website. So with that, without further ado, I hand over to Patrick. But before, my apologies, before I go to Patrick, I'd also like to introduce our interpreter. This is being interpreted in French as well, Tazara, and my colleague, Yubika Latinovic, who also works in the science translation team in WHO. Who's also here to support this webinar. So over to you, Patrick. Let's hear what we know about the Sudan Ebola virus and the implications of the current outbreak.
Thank you very much, Supriya. Good afternoon, good evening, and good morning to those joining us on this webinar. So as introduced, I'm Dr. Otim Patrick. I am an epidemiologist, but currently also serving as the incident manager for the Ebola response at the WHO Regional Office for Africa. I'm glad to be joined by my senior colleague, Dr. Miriam. So I will take you through the first part of this presentation that looks at the historical background of the Sudan virus, and then also talk briefly about the epidemiology of the outbreak in Uganda. And then Dr. Miriam will take on the second part of the presentation. So just to provide some context, so the virus that we are talking about today, the Sudan virus or the Sudan Ebola virus, comes from the Filoviridae family. Within that Filoviridae family, you have the genus called Ebola. There are several viruses within the Ebola virus genus, And as you see in the diagram on your right, they have been classified into three. There are those in the center of the circle, which have shown human infections associated with disease. And these ones include the Bundibujo Ebolavirus, which was identified first in Uganda. You have the Ebola virus, which was identified in the Zaire then you have the Sudan virus, and then you have the Thai forest virus. Those four have been associated with human infection and disease. There's one virus, the Reston virus, which has caused an infection, which has been documented, but there was no resultant disease arising from that. And then the last one, which is the latest of these genus that was identified from Bombali in Sierra Leone, then completes the viruses within this genus. But for today, we will just be focusing on the Sudan virus, and we'll discuss a little bit. So the other second thing that I wanted to clarify, because we are all globally so much used to the EVD nomenclature, but there was a revision of the classification of the disease caused by the filoviruses, and this has been published. And when you look at the diseases, the category of the diseases caused by the Ebola viruses, all the ones I've listed, they are collectively referred to as the Ebola disease. But when we go to the specific diseases caused by the specific viruses, the one that we are dealing with, which is the Sudan virus, causes a disease that we refer to as the Sudan virus disease, which is SVD. So the nomenclature or the acronym EVD is really reserved for the Ebola virus disease, which is caused by the Zaire species from this genus. So that is the other classification that I wanted, the clarification that I wanted to make. If colleagues want to find more details, you can refer to the ICD class, the International Classification of Diseases, the version 11, that has more details on this particular one. So for the Sudan virus in particular, this virus, as we know, was first identified in 1976 in two simultaneous outbreaks that happened. There were two simultaneous outbreaks that happened in 1976. One was in Zaire, and one was in the southern part of Nenden, Sudan, which is the present-day South Sudan, in an area called Nzara, which I actually happened to come from. So the outbreak happened in Zara. And then the virus that was identified in Sudan from this particular outbreak in 1976 was then later named as the Sudan Ebola virus. And then we have since had outbreaks happening mostly in Sudan, or the southern part of Sudan, or present-day South Sudan, and Uganda. So we have had these 7 outbreaks. The current outbreak that we are having is the 8th outbreak that we have had, and most of them have been very small outbreaks. This is only the one that occurred in Gulu, which was the biggest one with the 425 cases in 2000. And then the one that happened in Sudan, 1976, was 284 cases. The current one, which is still evolving then, is currently at 163 cases. So on average, we have seen the CFR ranging between 40 and 100% for this particular single outbreak that we've had. Of note then is most of these outbreaks, from the first 7 outbreaks, the over 700 cases that have been reported, there were around 15% of these were healthcare workers among those affected. From the current outbreak, we have around 12% of the total cases have been recorded among healthcare workers. So let me then talk about the transmission. So for all the zoonotic diseases, and particularly when we talk about the Ebola viruses, we have 5 key aspects to look at when we are talking about transmission. First, we know that there are virus reservoirs, and the common one that has been identified for these viruses, particularly the genus of the Ebola virus, is the fruit-eating bat. So you have the virus circulating among this bat population, and also then you have epizootics occurring when you have interactions between these bats and the other mammals. For instance, the antelopes and the other chimpanzees. So transmission of viruses happens. You have epizootic spread from the bats to these other mammals. Now, when a human being comes in contact with one of these, the antelopes or the chimpanzee, you then have the primary transmission, the primary human transmission happening. So the primary human transmission comes from handling infected, dead, or sick animals found in the forest. It can also be when there's a direct contact between an infected bat and the human. Now, for this particular outbreak in Uganda, we are still looking at what the primary human transmission could have been. There are both virological, ecological, and epidemiological investigations ongoing to identify the exact source of this transmission. However, the genome sequencing that was done on some of the initial clusters identified is showing that this particular virus is really closely linked to another outbreak or the other viruses that were identified in previous outbreaks in Uganda. So it could be that the virus is has been circulating in the ecosystem, in the bat population, but then as investigation go on, we'll be able to pick to come on with more definite answers to probably the index case or the first case that got infected that started the primary human transmission. Now, from the primary human transmission, we then have the secondary human transmission, the person-to-person transmission that occurs now through direct contact with body fluids, secretions on organs, or people, contact with dead body. And really, most of the transmission happens when people are from the virus. And then you have amplification of transmission happening usually in the context of care provision, and the common one is in the health facilities. And like I mentioned, we have had a number of clusters linked to healthcare associated transmission in this particular outbreak, and currently we have around 12% of the total cases being healthcare workers. So then let's come to the presentation. I think this is the most challenging part of let me say, for the Ebola disease in general, because most of the symptoms are non-specific. The symptoms are non-specific, and therefore clinical diagnosis is very difficult. For a tropical country like Uganda and most tropical countries, the common causes of febrile illness, which constitute the differential diagnosis for this particular virus, will include, things like yellow fever. We have an outbreak occurring currently in over 11 countries in the region. You have malaria, you have typhoid, you have shigellosis, and other viral and bacterial infections. So when you have a patient that presents to a health facility, if there has not been prior history of exposure or contact to a confirmed case of Ebola, it's very, very difficult for a clinician just by looking at a patient to say this could be Ebola. So it's very important then to take the history, looking at exposure to area where there's an ongoing outbreak, contact with a suspected or confirmed case, contact with a dead or sick animal, and then contact with a dead body. Sometimes not only of a confirmed case, but somebody who dies of an unknown cause or some suspicious death with symptoms that are suggestive of a viral hemorrhagic fever. And also there are fomite transmission, especially when a patient presents with wet symptoms, they are vomiting, they have diarrhea in a health facility, and there has not been thorough disinfection and decontamination of the area where this person was managed or sat in the health facility. If another patient comes and follows this patient, it's easier for this person to pick fomite transmission and then also be able to trigger another transmission. So one of the questions that people have asked is that what is the difference between then the Sudan Ebola virus and then the Ebola Zaire? So if you look at the historical data that looks from the previous outbreaks, and in terms of the presentation, you will see some slight differences in the presentation. For instance, when you look at the Ebola Sudan in the previous outbreaks, some of them, the fever has been most of the cases, the headache has been in most of the cases, the abdominal pain has not been so much, but also in the Gulu outbreak in 2000, we had abdominal pain. The current outbreak, we have seen abdominal pain. You have diarrhea being very prominent, but when it comes to the hemorrhage, you'll see that the hemorrhage is not as so pronounced like you would see in the Ebola Zaire. So one of the things that has been very clear from previous outbreaks is that the case fatality rate has been much lower for the Sudan outbreak, Sudan virus compared to the Ebola Zaire. However, when we look at the current outbreak, looking at some of the data that we have from around 160 patients that have been looked at, we have seen that fever is reported in 77% of the cases, general body weakness in 48%, vomiting in 46%, diarrhea in 41%, and headache in 40%. So like I mentioned earlier, you will see that majority, the top 5 symptoms are really non-specific symptoms. There is nothing that can trigger the index of suspicion of a healthcare worker that this could be Ebola. You will see that then unexplained bleeding comes in at 12%, which is very, very, very low. Then the other issue that we are seeing currently is convulsion in some of the patients presenting late, in the late stage of the disease. So most of those we have seen that present with convulsion unfortunately end up dying because then their condition is advanced. It's still where the colleagues in the field are trying to investigate further to identify whether the convulsions are due to issues to do with the low or hypoglycemia, low blood sugar levels. Could it be due to the fever that is caused by the virus or due to other causes? So I'll just rush through quickly in terms of the characteristics of the outbreak. So as we see now currently in Uganda, we have 9 districts affected. And in these 9 districts affected in the last 24 hours, actually in the last 7 days, we have not had any new confirmed case. So we have 141 cumulative confirmed cases. We have 22 probable cases. So that brings the total to 163. We have 5 confirmed cases currently on admission. We have not had any death in the last 24 hours. Cumulatively, there have been 55 deaths among the 141 confirmed cases. And most of these deaths have happened in the treatment center, 49 of them, 5 of them in non-Ebola treatment facilities, and then only 1 has happened in the community. So when you look at the CFR, it's 39 among the confirmed cases and 42% among all cases, which is not different from what we have seen in the previous outbreaks. In terms of healthcare worker infection, we have 1 healthcare worker in admission currently. There are 19 cumulative infections among healthcare workers. And I must hasten to add that a number of the healthcare workers were really infected or exposed at the beginning of this outbreak before we knew that there was it was confirmed as an Ebola outbreak. And some of them really were exposed in the course of providing routine care, such as a surgery with a patient that presented with an acute abdomen. So unfortunately, we have lost 7 healthcare workers. And there has been significant number of recoveries. We have 81 people that have recovered so far. So this is the EPI curve showing the progression of the outbreak. We will start it with the probable cases. These were the community deaths that were identified. And then we had the first confirmed case on the 20th of September. And since then, we have had 2 peaks. The first peak was really associated with the clusters in the epicenter in Mubende district, and then the second peak due to cluster in the neighboring district of Kasanda. So if you look at the cases by EPI week, we have seen a decline in the last 3 EPI weeks. So there has been consecutive decline. And you can also see here that we have had just prior to the 11th of November, we have only been having 1, 2 cases per day. So we're really hopeful that then we are on our way to contain this particular outbreak if we don't get any new surprise. So cumulatively, most of the cases have come from Mubende district, which was the initial epicenter that has 64 out of the 141 confirmed cases, and Kasanda district. Kampala city has only 17 cases. And we already have 2 districts out of the 9 affected that have exceeded 42 days without any new case. So we can comfortably say that we have active transmission in the last 21 days in 7 out of the 9 districts. In terms of the gender and age distribution, we are seeing that 60% of all cases are male, and then 40% are female. There has been a gender shift. At the beginning of the outbreak, we had more females than male, but now we have more males than female. And then the most affected age group, as we see, is 20 to 39, which are the most active segment of the population. Then I wanted to point out that we have also had a significant number of children involved in this outbreak. Cumulatively, there have been 35 children affected. Unfortunately, the CFR among the children have been much higher. So we have over 62%. And then most of the children infected and the deaths happened also at the earlier phase of this outbreak, where we had intense household level transmission. And the most affected age group with the high CFR was really also the 0 to 9 age group. As you can see, 0 to 4, there have been 12 alive and 2 dead, 5 to 9, 5 dead and 10 alive. So one of the issues has been the provision of pediatric care, but also it was noted that a number of these children presented with co-infection with malaria. The other issue I want to talk about is that we've been monitoring the reproductive number, the basic reproductive number in this particular outbreak. For the last 1 week now, the R0 has gone below 1. So as we can see that we are not having many cases being reported. So we had a spike of 5, 5, and 6. The R0 was 5, 5 here, and 6. And this was related to the clusters that I explained earlier on. And on average, we have seen a serial interval of like 10 days. That is the days between one case and the subsequent contact developing symptom. So the biggest places of exposure have been the unsafe burials at the beginning of the outbreak. There have been nosocomial transmission, as I explained, due to suboptimal IPC. And this was also high at the start of the outbreak, when most clinicians did not know that there was an outbreak. We have had a large number of family clusters driving transmission, and that explains the high number of children. And we have also had some transmission happening at places of traditional healers for some people who prefer to seek alternative medicine. So I will stop here, and then I will hand over to Dr. Miriam to take the second segment of the presentation. Over to you, Dr. Miriam.
Yeah, thank you very much, Patrick. Good afternoon, good morning, good evening, colleagues. Miriam from, I am currently currently in Uganda supporting the Ebola response. And I would like to share briefly about the response interventions that are going on here. I want to say that I've been part of the previously about 6 Ebola outbreaks, but I can say that each outbreak response is different. The strategies may be the same, but the dynamics are different in each response. So in this response, we have different pillars. We'll talk about coordination. Currently the coordination is anchored at the highest level with the Ebola of the government, with the Ebola task force under the office of the Prime Minister. And there's strategic and technical leadership by the Minister of Health that chairs a strategic meeting every week to review progress and set policies as necessary. They have national and district incident management teams activated as cases are detected in the different districts. And we have a scenario-based response plan that is guiding the response. Partners are providing support, technical and financial, material, logistical at both strategic and technical levels. And we have coordination decentralized as close as possible to the epicenter in Mubende. The National Coordination Center is in Mubende. The other pillar that is functional is the risk communication and community engagement pillar, which is very critical for getting the population to understand about Ebola, its transmission, strategies for its prevention, and limiting the transmission in the community, hospitals, and the different institutions. So they've developed many IEC materials and translated into local languages, and the process of dissemination of these materials is going on. Their dissemination of materials, the hard copies, but also print and use of print and electronic medias, a lot of radio talk shows, TV talk shows, and in Uganda, we find that there are radios that have penetrated deep into the community. So radio talk shows tend to reach to many people in the communities. They are also putting up community radio towers, which are used to relay messages to the community on issues of interest. There's a lot of myths and misinformation, and so a lot of effort ongoing on infodemic management. Under community engagement, we have used anthropologists that have been deployed to study behavioral analysis and understand the key drivers, and they're helping us in trying to design interventions accordingly. The teams are holding structured community dialogues, and the Minister of Health leads several of these community dialogues to listen in and address concerns of people. They also hold webinars with the different groups like health workers or political leaders to give information. And so generally there is integrated, intensive series of community engagement sessions to try and get the community involved in the response. But I want to say that we are not yet fully there. In spite of all the effort, more is needed for us to be able to get the populations fully convinced and involved. Under epidemiology and surveillance pillar, we have surveillance teams activated in all the affected districts, and the sub-pillars include alert management, where communities are encouraged to identify any cases with the presentations. We have disseminated community case definitions and toll-free numbers that the communities can call to report alerts. We have teams that conduct in detail case investigation, and we have teams that are doing active case finding to ensure that we don't miss any transmission chains in the communities, and of course the contact tracing. We have also surveillance, indicator-based surveillance ongoing in the public and private facilities, especially in the public facilities. Private facilities are quite weak in this area, but we are trying to encourage them. We have mortality surveillance. This is in the affected districts mainly, swabbing all reported deaths to be sure that we are not missing any death due to Ebola. And in the epicenter, they are also conducting safe and dignified burials for all the community deaths. We have a team on epidemiological intelligence and analytics that is doing regular analysis to guide us in the response. Under contact tracing, we are using GoData, a tool developed by WHO to roll out to support the monitoring of our contact tracing. We try as much as possible to do comprehensive contact listing during the investigation, because we believe that contact identification and follow-up is key to early identification of cases and stopping the outbreak transmission. So the contact tracing teams have been activated in all districts and conduct daily physical follow-up. We started off at a low rate, but we have seen contact tracing follow-up increasing from 20% to 60% in the most recent affected district, Jinja, but in most of the other districts, it has gone up to 100%. Case to contact ratio is roughly about 1 to 38. In some cases, it is quite too many contacts per case, but generally the ratio is that 1 to 38. Usually it is around 1 to 20. So we see that here we are generally recording more contacts. Most of our cases have been from known contacts that we are following up, and they develop symptoms and become positive, as you can see here. But as we, in the last, maybe two weeks ago, we saw like 3 cases that popped up, not on the contacts, and we have had to really investigate them backwards to see where they were linked, and these dropped the proportion of cases that were from our contact list. So this one was a bit of a setback to the response that we are trying to address. This one was a healthcare worker, and 2 were people from the community. So this is trying to look at the contact tracing in the different districts, and we can see that it starts off slow and goes up in districts like Mubende and Kasanda and Kampala, and then Jinja, which is just starting, the first one here. We see that we are still in the process of improving it, same as in Masaka. Next. Next, Patrick. Under case management, we know that for the Sudan virus disease, we do not have really therapeutics that have been found already effective. So the mainstay of treatment is aggressive supportive management, mainly rehydration and pain management, treatment of electrolyte imbalance, treatment of co-infections. We have a lot of malaria co-infections. The outbreak occurred at a time when there's a malaria upsurge in the affected region, so we have to treat malaria as well. But we are also using the MURI approach, trying on compassionate use the remdesivir and monoclonal antibodies, MB134, among the patients. We have, as they mentioned already, 80 survivors, and there is a survivor clinic that has been established to provide care to the survivors, and also to monitor if they have any long-term sequelae. Infection prevention and control has been one of the other key interventions. We have seen a bit of nosocomial transmission at the beginning of this outbreak. So there's been a lot of effort to strengthen infection prevention and control in the health facilities to avoid nosocomial transmission. Infection prevention, is targeting mainly the Ebola treatment centers to make sure that there is no infection of healthcare workers, involving rigorous barrier nursing measures, but also we deal with the non-Ebola health facilities where they strengthen screening, triage, and other standard precautions to avoid nosocomial transmission. There's training of health workers, provision of IPC supplies, and regular assessment to see that people continue to practice the relevant measures. We also conduct ring IPC activities. This around a confirmed case, you do infection prevention and control activities, maybe around like 5 kilometers around this confirmed case, and make sure that there is no transmission within the community and health facilities. And then, of course, we are trying to do institutionalization of these IPC measures. We developing IPC guidelines and standard operating procedures, because we believe that infection prevention and control should be a way of work in every health facility, even before outbreaks. There's also a process of supporting countries around Uganda, even districts that are not infected yet in Uganda, to enhance readiness. WHO conducted a risk analysis in the region And based on several criteria like the proximity to the epicenter, which is Uganda, trade and regional connectivity, cultural and social connections between the countries, ease of mobility, we categorized countries into high-risk countries that include Rwanda, Kenya, Democratic Republic of Congo, and South Sudan, then moderate risk, that include the Burundi, Central African Republic, Ethiopia, and Tanzania, and then low risk, which are the other countries in Africa. And so based on the risk level, the countries are being supported to implement readiness activities so that in case there's a case exported to their territories, they are able to detect quickly and manage. So there are weekly coordination meetings with the countries to assess progress, but also help them to identify gaps and close them. There's been efforts at capacity building, preparation of health workers and health facilities for case management and infection control. They've trained people on risk communication and community engagement, laboratory diagnosis, and all the relevant skills and knowledge that is needed to make sure that they are ready. There's also work going on enhancing capacities for points of entry to screen and contain suspected cases of Ebola, because people would mainly come in through some of these points of entry. There's been contingency planning in the countries, including 72-hour planning to guide them on what they would do in the first 72 hours after getting or detecting a case. We have seen countries, some countries are planning simulation exercises to test their readiness. These include Burundi, Kenya, and Zanzibar. About vaccines and therapeutics, as I said, there are no approved therapeutics, but neither is there an effective vaccine yet. So WHO is partnering with the country to conduct studies on candidate vaccines. A randomized controlled trial is being planned, led by Makerere Lung Institute. It is co-sponsored by both Ministry of Health Uganda and WHO, and they are planning controlled randomized controlled trial using ring vaccination approach of contacts. Contacts will be randomized to vaccination either immediately or in 21 days' time. There are several candidate vaccines, but the one that has been approved for Uganda is CAD3 by Sabin Institute for now, and is expected soon. So the study should be able to start soon. The preparations have been completed. But there are 3 recommended vaccines for study at the moment. Now for the therapeutics, again, as I said, there's no approved therapeutics. In addition to the compassionate use, there's also randomized clinical trials that are being planned. The protocols are under development, and they will be tried in Uganda as soon as they are ready. But as I said earlier, we'll continue for now with the compassionate use of the monoclonal antibodies and the antiviral remdesivir. I think that this brings us to the end of our presentation. We want to appreciate the Ministry of Health Uganda and the SVD National Task Force and Incident Management Team for the analysis of the information and the data that we are presenting, and the information on the interventions. Want to appreciate the WHO Country Office Uganda that I'm here supporting, and is doing a lot of work in supporting the response, and WHO, AFRO, and headquarters, and the viral hemorrhagic fever team at HQ for all the support to this response. We also want to appreciate the many partners in Uganda that are supporting this response, international and national. Thank you all. We'll take your questions now. Thank you.
Thank you very much, Dr. Miriam and Dr. Patrick. I really appreciate that you've taken the time to speak to us about this virus and this outbreak when you're actually in the middle of the response as well. So much appreciated. There are quite a few questions here, so obviously quite a lot of interest. I will just go in order. The first question is, what would be the potential scenario to get the disease spread over Africa or outside of Africa? This is for Jesus Uloa.
Patrick, please go ahead. Yeah.
Yeah, over to you, Patrick, if you'd like to answer.
Okay, so sorry, I had a challenge hearing. If you can repeat, please.
What would be the potential scenario to get the disease spread over Africa or outside of Africa? Is that likely?
It's so based on our risk analysis that we did, so on the risk assessment, it was ranked as low, so the likelihood is low. But of course, as we have seen before, in previous outbreaks, viruses can move and they move through people and people move. So there are measures that have been taken that further contribute to this low level of likelihood. One of them is that in Uganda, for instance, the Ministry of Health declared that all contacts are on no-fly list, so they are not allowed to fly out of the country. And the list of contacts is shared with the points, the immigration offices at the points of entry, so that these people are not allowed to leave. So efforts have been made to ensure that this is contained within Uganda and minimize the risk of spread to Africa and the other places. The other issue is that we know all African countries have very porous borders, so we only have limitation on how many borders we can control. And that's why the risk of spread is then to the region is highest through the land crossings. And that's why we have been working with the countries within the region so that they have capacity to quickly detect any cross-border spread and be able to contain this. So for now, I think the likelihood is low because of the measures that have been taken. And we continue to work on ensuring that any risk of spread beyond the Uganda border is much reduced. The best way to stop spread is to contain the outbreak where it is happening. And that's why a lot of effort has been geared towards the response at the different hotspots. Thank you.
Thank you very much, Dr. Patrick. The next question is by Jibril Khalidou. What could explain the decrease in Sudan virus mortality in 2022 compared to previous epidemics? Do we have, who would like to take that?
Okay, I can say something and then Dr. Miriam will complement. So I think one of the things that over the last few years, our knowledge of the management of Ebola has improved significantly. And also the level of confidence of healthcare workers have improved. So there have been significant trainings done for healthcare workers, and the understanding of how to manage the physiological changes that happen when somebody is suffering from the disease has also improved. So it's the combination of the supportive care, and also one of the slides we didn't show is that the mortality has been high among people who present late to the facilities from day 4, day 5 after symptom onset going forward, but patients who present very early in the onset of the disease, the mortality has been very low. So it's a combination of the early presentation of a number of the patients in the facility, plus the intensified aggressive clinical management that Dr. Miriam had talked about, which has contributed to the reduction in the mortality that we have seen in this particular outbreak.
Thank you.
Maybe I could also add that the improved knowledge of the people that are providing the care, most of the people that are providing clinical care are people that have participated in several previous outbreaks and learned along the way. So they are experienced in the care and so are giving good supportive care. And especially when the patients turn up early in the course of illness, we are seeing better survival chances. Over.
Thank you. Very important points there. The next question is measures being put up to contain this outbreak, I think has been addressed in your presentation. The estimated R computed on cases by date of symptom onset. Perhaps you could type that answer because that may not be of interest to everyone else here. The next question is by Jean-Pierre Van Gertruden. What is the protective and clinical efficacy of the existing vaccines against the Sudan strain?
I think this is also something that I have addressed to say that there's no vaccine at the moment with the clinical efficacy, proven clinical efficacy against the Sudan strain. And so we are just trying out candidate vaccines. And these candidate vaccines have only gone through phase 1. So this is going to be a combined phase 2, phase 3 study. So we cannot tell about the efficacy of the candidate vaccines at the moment. Over.
And the next question is about protecting people, the community engagement and what is being done there to protect people. It's by Tanisha Rathor.
I think the person is asking about what is so protective clinically about community engagement. Why are we prioritizing community engagement? If I understand this well. Okay. Yeah, and you know, the outbreak will start in the community. They have behaviors and activities they get involved in that cause this to happen and get transmitted. And by engaging the community, we help them to understand the disease, identify the behaviors that are enhancing transmission, and it is through their engagement and empowerment that they can change behavior and support the response in limiting the transmission. We have seen that without communities being engaged and being positive and participating in the response, it is more challenging than if you engage them and they are with you in the response. So community engagement, we find, is a very important aspect of the response. Over.
Thank you. Indeed, communities, as we've seen in recent outbreaks, are at the core. So Prudence Hamade has the question, which also you have addressed a bit. Have any new treatments been developed for Ebola, such as antivirals or monoclonal antibodies? You've addressed it. Would you like to expand on it, Miriam? Or?
Yes, I can say that there are about 4 therapeutic agents that have been tried out, 3 antivirals and 1 that have been developed and 1 monoclonal antibody, and they are all for trial. And but monoclonal antibodies and remdesivir are being given out even on a compassionate basis as the trials are being planned. We cannot tell at the moment whether they are very effective or not. Maybe as the study goes on, we'll be able to tell that. So we can say that there is no therapeutic that we are very sure of at the moment. There are trials ongoing, and therapeutic, rather the compassionate use is based on the fact that we know in the past monoclonal antibodies have been useful, and we think that maybe they could be useful in this case as well. Over.
Thank you, Dr. Miriam. The next question is similar. The next one is Russell Yusa Chiukanko, which is a slightly different question this time. It's about the infodemic management. What has been done concretely about infodemic management during the fight against Ebola? Do you have infodemic managers deployed there?
Maybe I can say something and then
yes, Patrick, please go ahead.
Dr. Miriam can add. So I think for the infodemic management, we learned a lot from the COVID response, and we also leveraged the structures that were put in place for the COVID response. We have what is called the Africa Infodemic Response Alliance, which is led by WHO, and we have leveraged their infrastructure to support on management of infodemics. And if you see online, you will find a number of what is called the viral facts, viral videos that they produce that responds to some of the information that has been picked. But the RCCE pillar, and that's led on the feedback mechanism that also does rumor monitoring or media monitoring and picks a lot of the infodemics from social media, from community dialogue platforms, and then on a weekly basis, responses are synthesized to address those misinformation that have been picked up. So this approach, which was used during COVID, has been deployed. And of course, we have a big team of RCCE and colleagues that are on ground. And Miriam had mentioned also the deployment of the anthropologists who have been very, very useful in picking out the community beliefs around the virus. And this has also then been synthesized into messages that address the concerns the population have. Thank you.
Thank you, Patrick. Miriam, would you like to say something more about that?
No, maybe we would move on because Patrick has said most of it.
Thank you. Then the next question in that case is from Yang Guo. And he has two questions. One is, since it's difficult diagnosis is difficult according to the symptoms, for example, sometimes with malaria and others, how can you raise the sensitivity of diagnosis? The second is, since there's still high transmission among communities and hospitals, how fast are the responses? Are they fast enough?
Okay, I'll also take a shot at this. And then, so first of all, as we have seen, the first line of detection is the healthcare workers when a patient presents at a facility. So increasing the index of suspicion of healthcare workers is something that we have been working on. One, to equip them with the case definitions. How can they be able to detect a suspected case? So all the healthcare workers, there have been series of sensitization webinars to be able to expose them to what the case definition is, and also to bring in their index of suspicion and have Ebola as a differential diagnosis when they are managing a case. But the other one is also then for them to take proper history, because we have seen then a number of, sometimes a contact tries to sneak from one place and go to the other place where they may not be known. So having a detailed history that tries to explore the possible exposure of this person, if they have been to any of the epicenters, or they have been involved in funeral or anything, caring for a person that recently died. So that detailed history that will enable them to red flag if this person could be a suspected case of Ebola. The second one then, in terms of the response and the community exposure and the transmission in health facilities. As I mentioned, there were a lot of exposure of healthcare workers at the beginning of the outbreak, and a number of them. One case that I need to give for clinicians to take note, for instance, there was a patient who presented with acute abdomen, severe abdominal pain, and they suspected that this was maybe an intestinal obstruction, and he was taken to theater, and operation was initiated, and turned out this was a case of Ebola. So there was an exposure of all the people who were on that operation team, everybody who was in that theater. So those are one of the issues that happen where we have huge number of healthcare workers exposed. The second one then is at the community level also. Initially, there was some resistance and you would have a case being kept in the house for 2-3 days before they can come up to be isolated. So the delayed isolation was due to some resistance from the community at some point. So the longer a case stays at the household level, the more interaction they have with the population and the more then the transmission happens. But over time, we have seen at the beginning, our time from symptom onset to isolation was like 5 days. But in the last 3-4 weeks, we have seen that the time to isolation has decreased significantly because one, there has been rigorous community engagement. The contact tracing has also improved, so we are able to detect cases early among the contacts. And so all these have really contributed to an improvement in the isolation of cases that has reduced the exposure in the household. The last intervention which the government has also done is that for contacts that are difficult to manage or in households where there is congestion, they have done off-site quarantine or institutional quarantine. Some of the contacts have been removed from the house and kept in facilities where they are given food and monitored so that their contact with the rest of the family members, especially for somebody who was a high-risk contact, is reduced. So when this person develops symptoms, he does not pass on the infection to other members of the family. And all that, these are things that have led to, as we are seeing now, a very low number of cases being reported in the last 21 days. Thank you.
Thank you very much, Patrick. That's very interesting and useful, I'm sure, especially for the clinicians amongst us. Miriam, would you like to add to that? You're muted, Miriam.
Sorry, I need to say that given the non-specific presentation of the disease, especially at the beginning, there's need for a high index of suspicion among the clinicians, especially in the affected districts and the high-risk districts that are neighboring. And so we have tried to educate them about this. And as you may have seen in one of our slides, they are taking many samples from suspected cases. And we, like in the last 24 hours, 90 samples taken and 0 positive. The previous one was almost 160 samples taken and 0 positive because of high index of suspicion and because of the non-specific presentation of the disease. But I think that we have to go this way in order to not miss the disease when it occurs. I just wanted to add that. Thanks.
Thank you. A very important point. So we'll go on to the next question now with Jeffrey Ruhangario, but that's again on infodemic management and misinformation and disinformation. I think Patrick addressed that already, and in the interest of time, because we're coming up to time, we will move on. The presentation will be shared. There's a question on contact tracing at public transport. How do you do contact tracing with public transport? Quick answer, either Miriam or Patrick, who would like to take that?
Yeah, it is not very easy, but what we try to do is to try and identify the people that used that same transport, if possible, and the people that border is basically the motorcycles. The motorcycles that could have carried the sick people to the different clinics and hospitals. But in general, for public transport, it is difficult. What is happening now, or what the people are trying to do, is to try and document who uses which transport, especially name and phone contact. In case of a positive case being identified and having traveled in your bus, then you are called upon. But it is not an easy task, I can say.
Thank you. The next question is, well, it's from Sylvie Fassin. It's in French, but I think she's asking, are there creches near the centers for children from the age of 0 to 7 years whose mothers have been positive or suspect? I think that's what she's asking. And Tazara, I'm wondering if you can help here with the question, if I've got it wrong. Okay. So Miriam, would you like to answer that? Are there creches for children?
These are 0 to 7 months or 7 years?
There's years, yes.
Okay, so we have seen in this outbreak a special situation where many children have 0 to 9 years have been infected, more than previous outbreaks that have occurred in Uganda. And of course, that was a challenge on the children. But in several of the homes, we found that the mother is a contact as well as the children, and maybe the mother gets symptoms and is admitted before the children. What we have done was to create quarantine facilities for high-risk contacts. So such children would be in the quarantine facility being taken care of, but by designated people and provided for as they are followed up as contacts.
Okay, thank you. So that's so we have now reached the end of our time. So maybe 1 or 2 more questions, and the rest perhaps we could send answers later. So the next question is about whether there's cross immunity of Merck and J&J vaccine against the Zaire strain.
And quickly say that no evidence to this effect.
Right.
Yeah.
Is there animals?
I think there was a problem with the question. The person probably meant cross immunity between the Merck and J&J vaccine against the Sudan strain, because the Merck and J&J vaccines are for the Zaire strain, but there's no cross reactivity with the Sudan.
I think that is exactly what he was trying to say. The Merck is for the Ebola Zaire strain, but there's no cross immunity evidence with the Ebola Sudan strain. Yeah.
Right. Is there animal surveillance going on?
Yes, there's ecological studies going on. They have studied birds. They are looking at monkeys and other animals in the forest, and their results are coming in slowly. Yeah, but I can say yes, they are going on. We were surprised to find that the bats that we were thinking so highly of so far were still testing negative.
Okay, so there is work there quite. So the next question is on probable cases and HCWs, which you've addressed, I think, in your presentation. We'll go on to the next one. Conscious that we've gone past time, what are the relevant lessons you can share for other countries to adopt as part of their EPRP?
Do you want to start off on that?
Yes. I think one of the biggest issue that countries have to consider is the issue of readiness. And we have discussed this on a number of different approaches, but it's very, very important that countries are able to put in place operational readiness. And it's not only preparedness, but having systems that are ready to go, rapid response teams that can deploy quickly, and supplies that can be used, and even financial resources that can be used to be able to deploy teams when an outbreak is detected. And always you never know where and when it will be detected. For instance, this place in Uganda where it's happening is the first time it's happening in that particular location. So countries really need to put in place that mechanism for readiness to be able to deploy. I think the second issue is also then about the surveillance. Most of our surveillance is really the indicator-based surveillance at the facility level. And sometimes, like in this situation, we miss deaths that happen at the community level. It's really critical that countries also look at issues of community surveillance as a key component that feeds into our indicator surveillance. And lastly, I think I will just stop on this one, and then Dr. Miriam can add, is also then the issue. It's not enough to develop your the emergency preparedness and response plans. It's really important that they are tested and the people who are supposed to respond know what is in these plans, and they are able to implement it so that you can have prompt response and rapid containment of any disease outbreak or any other public health event when it occurs. Over to you.
Yes, thank you very much, Patrick. I think you have summarized the key issues, being ready. And when we say ready, there are key things that are critical: the health worker education for suspicion, the laboratory needs, there's need to have clear laboratory that can do the testing so that you confirm quickly, and then a plan for case management. We realize that in many developing countries, you find that there's no identified maybe treatment facility for such cases. It is very important that we develop this and be very ready to handle such diseases. So I think the education of the health workers, the laboratory testing, and ability to respond to manage the case. Of course, also the risk communication skills being developed. Over.
Thank you very much, Miriam. Very, very pertinent for other countries, the key considerations for the EPRP for other countries, including lab testing, community engagement. With that, I think we've come to the end of a very, very interesting and very, very relevant webinar. Thank you very much to Miriam and to Patrick for taking the time to answer all the questions and to give us an overview of the virus and the current outbreak. There are still some questions, and there's one gentleman who also said that his question on infodemic management misinformation and its the impact of the interventions. So those perhaps we'll give written answers to those questions. I don't think we have the time now to respond to all of those, but we'll share the questions with you and perhaps give written answers if possible to some of those that were not responded to. We will share the presentation as well. Thank you very much for an excellent presentation that will be up on our website, as will the recording for this video. So once again, thank you. Thanks to all the participants from a range of countries, even though the time is not convenient for many countries, right from, of course, many African countries, but also, far west as Canada and the Middle East and some countries from the East. So we have, a range of participants. Thank you very much for taking the time to join us. And thanks also to Yubika and to Tazara for their support, and not least our two speakers, appreciation once again. And we will see you for the next EPI-WIN webinar, and all the very best with the response. Thank you. Bye.
Thank you all.
Thank you. Thank you.
Yes, yeah.
Bye. Gracias.
Looking at the comments. Now you feel good, eh? When you have something